Please rename yourselves in your accounts. I can see iPhone and some numbers in front of your videos. It will be nice if you rename yourselves so that we can understand who is participating. Please keep your videos open if you're not busy. Okay, 1 + 5, please change your name. Seven 72689. Also change your name, number to your name.
So now I'm back again.
Thank you.
So if you like, I could start if it's fine for you.
Yes, we can start. We can start.
Good morning from Vienna, Austria. I am very happy to be invited here, and I just want to thank very much Dr. Rapata. She has very much interest in our book, and we came together a few days ago. So it is a great honor to speak to your renowned audience. Today, I want to talk about homeopathy in emergencies, and I'm now retired. I've worked at the General Hospital of Vienna, or Medical University of Vienna, for about 40 years, and spending more than 30 years in intensive care medicine. And I'm now the president of the Austrian umbrella organization for holistic medicine, and it comprises several methods. I think it is to some extent comparable to the methods which are represented in the Indian Ministry of Ayush. It is now comprising about 16 to 18 several different methods. I'm also vice president of the Doctors Association for Classical Homeopathy and the first chairman of the German Scientific Society for Homeopathy. And I'm proud that we are cooperating with India since many years. Now I want to proceed to the
sir,
next.
A little bit welcome to you and warm greetings from our WICCI Council, Homeopathy, National Homeopathy Council. And we are really honored by your presence, and we are looking forward for your valuable guidance regarding the homeopathy in emergencies. I have always considered Dr. Michael Frass as my mentor. I was really interested about this homeopathy in emergencies since 2016, when I lost my husband in a critical condition where he was admitted to the hospital. And that story always I tell that that was the moment when I really started taking interest in homeopathy, how it would work in emergencies and how it can be introduced into the hospitals in India, so that there will be integrated medicine where homeopaths can work shoulder to shoulder with the conventional system medicines. Every pathy has its shortcomings, it has its limitations, whereas it also has the scope. So identifying the scope of every pathy, each physician, each surgeon, every pathy should work shoulder to shoulder for the welfare of the patients. And that is what is really needed for a strong healthcare system in any country. I welcome Dr. Michael Frass once again, and please start with your presentation. Thank you, sir.
Thank you so much for your introduction. I will now go to the next slide, but for some reason I cannot move forward. It worked just a few seconds ago, but now it is, I'm pressing the different, maybe.
Do you want to click the down arrow, sir? It will go down.
I'm just pressing the button down and also to the right side.
Shall I share the screen?
I will escape, maybe. Okay, I just start again. Okay, now it works. Sorry. Many greetings from the Doctors Association for Classical Homeopathy in Austria, also from the Austrian Society for Homeopathic Medicine, and especially also from the Austrian Society for Veterinary Homeopathy. I think collaboration between the different parts of medicine is necessary because patients, I think in almost all countries of the world, request complementary integrative medicine, including homeopathy. In my eyes, India is the leading country of regarding complementary integrative medicine, and I'm very proud to have the chance to cooperate. In Europe, I assume Switzerland to be the country which is very prone to at least 5 different methods like homeopathy, phytotherapy, anthroposophic medicine, traditional Chinese medicine, and neural therapy, which are part of official medicine. In my country, most of the conventional colleagues are not very well informed about complementary integrative medicine, especially homeopathy, so it is not a very nice situation in the moment. Now, just letting you know that as a homeopath, you might also be very interested in conventional medicine. Many years ago, together with 2 friends, I developed the Combitube, which is a device used in emergency intubation, for example, cardiac arrest, when you are not very well trained in intubation. And it helps to secure the patient's airways, and it also helps to oxygenate sufficiently during emergencies. And in 1999, I was invited to give lectures throughout India, and I enjoyed a 2 weeks tour, including a lot of sightseeing, and this was a very nice time. I was also in Vellore with Dr. Chairperson, and there we used this Combitube in an intubation trainer, as you could see here, and it was a fantastic time. Now, I think it's necessary to have knowledge about state-of-the-art medicine, which I would like to call conventional medicine. You have to gauge benefits and risks, and of course, there is not allowed to withhold any vital conventional medication. What I like very much with conventional medicine is the diagnostic evaluation, like laboratory medicine and all the radiological examinations. It is important to exclude mechanical causes. I think it is not possible to use homeopathy as the first method in mechanical diseases, but for example, after bone fracture, I have had a lot of very good responses in skiers. You know, Austria is a skiing country, who have broken bones, and to help to bring the bones together. The treatment is also dependent on the knowledge, and female doctor, Dr. Baltasis, she has worked in a neonatal intensive care unit, and as you know, the neonatals are not prone to talk to the doctors. However, she used the vegetative symptoms to treat these very small patients successfully. And of course, it is necessary to gauge whether homeopathy is suitable. And we also combine different methods of complementary medicine. What is my important message is there should be a constructive dialogue between conventional and homeopathic medicine. And I'm very much in favor of Samuel Hahnemann and his law of similars, which you know very well. And in November, there's a yearly conference in Köthen in Germany, where Hahnemann has lived before he moved to Paris, and this house where he lived is still there, and it is a very nice museum, and the library is just very close to it. So we have published a book in 2007 in German language, and fortunately it was translated into English a few years later. A German second edition is available, but has not been translated into English so far. The Narayana publishers are also not very quick to provide the new books, but Dr. Rajeshwari Rabata, she did not stop, and now I think we have a very good combination and communication with Narayana publishers. Now, it's the question whether homeopathy in intensive care makes sense. You know, depending on the underlying disease of the patients, the mortality in intensive care units may be up to 35%. I'm talking about internal intensive care units, not about postoperative. You know, if you are going to a surgery, usually the surgeons perform surgeries only. Surgeons perform surgeries only in patients with a relatively good prognosis. But in intensive care unit, patients are coming because of lung failure or of renal failure, cardiac failure, or after resuscitation, and therefore prognosis may be very bad. It's not so much a physical, but much more a psychological challenge for the medical staff and nurses, as well as for the relatives and family members of the patient. Now, the question is whether homeopathic therapy in such difficult patients is meaningful. And the problem is that correct performance of an anamnesis is not possible because the patients I'm talking about, almost all of them are unconscious. You cannot talk to them. It's not easily possible to get a connection. But you can look to the vegetative symptoms, and in addition, I always ask the relatives what has happened before. For example, the patient I've never seen before had to be admitted to the intensive care unit, and I talked to the relative, and he told me he had repeated attacks of rheumatic arthritis with swollen knees and red color of the knees and of the several joints, and he had also a lot of pain when moving. And such an attack has happened just a few days before admission to the ICU. So I told him, I think this Bryonia alba might help. And in addition, the reason he was admitted was lung failure, pulmonary failure. So with Bryonia alba, his situation improved very quickly. And I think this information of the relative was very, very important and helped to save this patient's life. And I think there should be great attention regarding assessment of symptoms because of interaction with lots of other conventional therapy. You know, I remember most of our patients had at least 7, 8, 9, 10, and even more remedies at the same time, conventional remedies. And this makes the judgment very difficult. Now, how can you apply the globals? I think you do it in the same way as you do in your conscious patients. You can apply them sublingual, and many times the ventilated patients, and especially if they're orally intubated, it is not so easy to find an access to the oral cavity. But usually if you have, even if the mouth is almost closed with these tapes, there's always a small hole. And I think it's also okay if you cannot put the globals forward to the tongue. It is fine if you can apply them between the lips and the gums, just to the oral vestibule. And the number of globals, in my eyes, is not important. You know, some colleagues say you have to apply a certain amount of globals. I think it should be at least 2, as has been recommended by Hahnemann. But you almost always find a way, but don't put them into gastric feeding tube or something like this, because it should be in connection with the membrane of the mouth. In some patients, there might be a profuse salivation, and therefore you should be careful that the globals should not be hauled out of the patient's mouth. And about a few minutes before, afterwards, there should be no hygiene of the mouth. I think 15 minutes may be too long. I remember when I was in New York many, many years ago, together, we have rented an apartment together with a colleague. And this, in the evening, we wanted to get out, or to get out with this couple. And the lady, she touched, when she slipped into her shoes, she touched a heating tube. And immediately she had severe pain, and she also had some boils. So many years later, she reminded me what I told her. I have something for you, and I gave her, of course, I would say countries, everybody of you knows it, or now it's called Luther officinalis in my country, these countries. And she told me in the moment when the globus touched the mucous membrane of her lips or her mouth, the pain removed, and 5 minutes later, these boils removed. So maybe everything happens within a few seconds. Now, what may be different in intensive care patients, critically ill patients, is there might be frequent repetition of homeopathic medicinal products necessary, even in high potencies. Now, previously, I called this global remedies, at least in the English-speaking areas now, they call it homeopathic medicinal products. So it's something very not too easy, so easy to pronounce. Now, as already told, there may be difficulties in assessing outcome because of the highly reduced consciousness or even unconsciousness. Therefore, clinical signs have to be taken into account. At least in my country, the problem is there are few qualified homeopaths, but you are you are fortunate in your country, you have thousands of trained homeopaths, and this is a very big advantage. What I will tell you now is no suggestion. It's just it's only suggestions, but no guidelines. It's just what I have seen, but it doesn't mean that there's no other way to find the right homeopathic medicinal products, or let's say remedies. I would be happy if you have, if you find, or if you can report about your successes in critically ill patients. What I think is so fantastic in intensive care, patients are monitored perfectly, you know, heart rate, blood pressure, oxygenation, lung parameters, everything is continuously, more or less continuously monitored. So you have the perfect patient. It's much easier to treat than critically ill patients than a patient outside because of this perfect monitoring. Now, the familiarity of homeopaths with the levels of potencies is important for the selection. You know, at least in my country, if we talk about the use of potencies, if you ask 3 homeopaths which potencies you are using in which situations, you might get 5 different answers. And of course, what I tell you is no restriction. However, it should be an exchange of ideas between interested homeopaths. So, as already told, since many patients are suffering from a heavily reduced consciousness state, clinical signs are important as indicators for homeopathic therapy. In acute diseases, there might be quick change of these homeopathic remedies necessary. What I believe, a shorter time intervals for high potencies is allowed, because I assume the energies of these remedies may be exhausted much quicker in those patients. Some indications maybe sepsis, bleedings, abscesses, secretions, but like in chronic cases, there's, in my eyes, no restriction of the application of homeopathy in critically ill patients and in emergency medicine. Exceptions are mechanical reasons. Weight and attention should be kept regarding the limits between conventional and homeopathic medicine. And of course, it should be a balanced but not fanatic homeopathy. Now, Hahnemann, more than 200 years ago, he already had some insight in those patients. And in paragraph 7, he states, now as in a disease from which no manifest exciting or maintaining cause has to be removed, we can perceive nothing but the morbid symptoms. It must be the symptoms alone by which the disease demands and points to the remedy suited to relieve it, and moreover, the totality of these its symptoms. It is not necessary, in his footnote, he states, it is not necessary to say that every intelligent physician would first remove this where it exists in this position, thereupon general ceases spontaneously. He will remove from the room strong-smelling flowers, which have a tendency to cause syncope and hysterical sufferings, extract from the cornea the foreign body that excites inflammation of the eye, loosen the over-tight bandage on a wounded limb that threatens to cause mortification, and apply a more suitable one. Lay bare and put ligature on the wounded artery that produces fainting. Endeavor to promote the expulsion by vomiting of belladonna berries, etc., that may have been swallowed. So, you know, he was just a very intelligent guy. So he had already some answers to questions which are still actual today. Now, if possible, members of the family and nurses should be informed about the upcoming homeopathic therapy, because there may be the appearance of symptoms after administrations of the homeopathic remedies. For example, eczema might occur, changes of the mucosal membrane. The sputum may be increased, there may be in bronchial exudate, diarrhea, liguria, and so on. Now, I'm just showing you how I applied, and of course you should wear gloves. I don't do this in this picture. In addition, for emergencies in my patients, I have put together 20 remedies. Actually, I have changed coffee Arabica to phosphor C200. And I think this is very nice for patients. For example, usually patients become ill in the middle of the night or when they are traveling. So they can call me and I tell them which remedy to take. Now, I want just to show you a few case reports. A female 57-year-old patient, her father had died 9 years ago because of cardiac insufficiencies. 2 sisters are in good health, as well as the mother of the patient. 5 years, at the age of 5 years, she underwent appendectomy, and at the age of 9 years, tonsillectomy after recurrent angina. Previous diseases included stomectomy 20 years ago, as well as surgery of a meningioma 13 years ago. Afterwards, she was less resilient, and postoperative there were several episodes of epileptic seizures, especially in mental stress situations. Now, when taking the history, she reported the sleep position mainly on the back. There was a tendency to diarrhea. She was thirsty for water. For 14 years, she had taken oral contraceptive pills. There were 2 childbirths. She was from the profession, a teacher, and preoperative to the surgery of the meningioma. She was very vital and agile, but afterwards it was opposite. Now she was anxious when alone. Some weeks before, the patient didn't feel well and was depressed. A day after a bike trip with her husband, with whom she had not a very good relationship, sweat dropped from her forehead. She felt even physical threat from her husband. The acute event was that one day in spring, her husband found his wife unconscious when he returned home. She was immediately brought to the next hospital, and in the department of neurology, it was assumed that an intoxication had occurred. Now, in the hospital, cardiac arrest occurred, and there was protracted resuscitation. You remember I showed you this Combitube, this device to secure the patient's airway, and I'm sure such an airway, and you know there are several airways like this now on the market, such an airway emergency airway has not been used, and there might have been hypoxia of the brain. Now, therefore, the patient had to be transferred to intensive care unit, and there were, of course, conventional examinations and therapy. She received a tracheostoma and artificial respiration. She was mechanically controlled, ventilated, and she received enteral nutrition. Now, from a neurological side, an Epalic syndrome was predicted. Of course, it was too short to diagnose it. In the imaging methods of the cerebral computer tomography showed no sign of an apoplectic or hemorrhagic event. There were only signs for minimal hypoxic damage. But she was treated as a head injury patient with elevated head position. But as far as I know, this type of positioning is not confirmed by evidence-based medicine. She received conventional ICU therapy. I was consulted by phone on the second day. At that time, I was at a conference in Germany, and I like very much sightseeing. So at this time, I was just in a museum. I have never seen this patient before. And when I was told about the situation, I confronted the relatives with the hopelessness of the situation. I said, no, we cannot do very much. However, one of the family members, she demanded vigorously homeopathic treatment. So I recommended due to hypoxia 5 globals of cuprometallicum, CH200. And if you look to the literature regarding cuprometallicum for hypoxic damage, for example, in Van der See's miasms in labor, there's a case 37. The amnion liquid contains meconium, and he was born with asphyxia with consecutive brain damage. And Friedrich Graf, he recommends cuprometallicum in asphyxia of newborn. And maybe something has changed, but I have looked to reference works of the MAC repertoire using the keyword brain damage, and I found only cuprometallicum as well as lachesis. Lachesis was in the second column was in the 2 repertoires, and the column only univalent listed. Now, the next day, to the surprise of the treating physicians and nurses, the patient was completely responsive. They said it's a wonder, and however, the condition was, of course, still reduced. Now, paradoxically, homeopathic therapy was forbidden. I don't know why, but the patient improved and was transferred to the general ward the next day. In addition, the sister, she also applied locally on the skin of her forearm arsenicum album. I have no idea, maybe we can discuss this later, whether or not you have any experience with application on the skin in case it is not possible to apply globules in the oral cavity as it was in this case. Now, at the follow-up, 6 months later, the patient was in good condition. She was dancing again and kept the house largely by herself. She only complained about weakness of her memory as well as listlessness. Now, I think intensive care is an indispensable discipline, especially, of course, postoperative intensive care. However, in the internal intensive care, you find an increasing number of single, multi-organ failure, of course, now with COVID-19, sepsis, systemic inflammatory response syndrome. For those who are not so familiar with this SIRS syndrome or systemic inflammatory response syndrome, this is the same like sepsis. However, you don't find any agent causing this sepsis. In many cases, patients have no bacteria, viruses, or mushrooms being responsible for this difficult state. You may also use it in burns and trauma, cardiopulmonary resuscitation. It might be life-saving. Now, the new developments of intensive care during the last 5 decades comprise several modes of mechanical ventilation, and in addition, vena-venous pump-driven hemofiltration, sorry, spelling error, as a continuous renal replacement therapy, cardiovascular therapy, and also extracorporeal membrane oxygenation. And monitoring is now performed at a very high technical level. Again, this is a situation, an emergency, where the Combitube has been used. On the right side, you see a situation where the windshield was broken after a car accident, and through this open windshield, the Combitube was inserted. So this was happening in Germany, and this patient survived very well. Now, this was a situation also many years ago. I'm sitting in front with many kilos less, but it was a very good time. Another patient was a 61-year male patient, and he was admitted to the hospital because of a severe acute interstitial pneumonia requiring mechanical ventilation. This is a life-threatening disease with concomitant sepsis, and most patients don't survive. After 2 weeks of controlled mechanical ventilation, there was a slow improvement of the general condition of this patient. And when he was released from the hospital, he had anticoagulation with fluoxetine. However, he stopped anticoagulation by himself. In his history, there was a tonsillectomy at the age of 6 years after recurrent angina, and at the age of 13 years, he suffered from a perforated appendicitis. He also reported blood poisoning. It was something like a beginning of the, might have been a beginning of a sepsis after a wasp bite. And surgery of a right inguinal hernia happened at an age of 35 years. The acute event was that 2 months after discharge, the patient had to be admitted again to the intensive care unit because of severe dyspnea, fever of almost 39 degrees. And there was heavy pain during inspiration. Auscultation revealed crepitation in the right upper lung. Now, the diagnosis was confirmed of pulmonary embolism and status post or after pneumonia. He received a non-invasive ventilatory support using a helmet as a conventional therapy, and chest X-ray showed a well-defined shadow in the right upper lobe, and this was compatible with the diagnosis of pulmonary embolism. Now the patient received anticoagulation with 1,000 international units of heparin, together with an antimicrobial therapy with imipenem cilastatin. Now I looked to the repertoire, and it comprised embolism, inflammation of the abdomen with peritonitis and so on, and generalities, septicemia, blood poisoning, and also wounds, bites, stings by poisonous animals. You remember the wasp. Stings of insect general and inguinal hernia. Now, the differentiation of remedies under the clinical aspect of pulmonary embolism included lachesis muta, medication suggested because of the acute lung embolism and the history of sepsis. Differential diagnosis included Crotalus horridus, Crotalus cascavella apis. However, Ghar was not mentioned with bites or stings of animals, at least at this time I couldn't find it. The therapy was 5 globals of Lachesis muter, CH200 on day 0. And during the next 3 days and nights, the patient suffered from intense perspiration. There was an improvement of the respiratory situation, as well as chest X-ray and the ventilatory pressure support via the helmet could be cancelled. And suddenly, the patient reported a painful spot on the skin of his left forearm, and he remembered that this wasp bite has happened 25 or even 35 years ago on the same spot with subsequent so-called blood poisoning. And I think this is a fantastic sign of Hering's rules that previous symptoms reappear. The patient improved continuously and started to work again. After 11 years of good health, he died of cardiac arrest. Actually, this patient was president of Austria. So he was my most prominent patient at this time. Now, Lachesis is one of the remedies I like very, very much. You will see it later on. It may be used in infectious diseases, in severe septic processes, abscesses, venous inflammations, pulmonary embolism, joint rheumatism, dysmenorrhea, dark bleedings, and so on. One of my preferred cases is poisoning with Amanita phalloides. I don't know whether Amanita may be also found in India. Maybe you can tell this to me later. The history is there was a 69 years old female. Now I find out it's exactly the same age as I am now. She had a poisoning with Amanita phalloides at the end of August 2002. Furthermore, her history included arterial hypertension, myocardial infarction, and decreased renal function with stress-induced dyspnea. The acute history on day 0, together with 3 people, she ingested young, big mushrooms, which she got from the neighbor. He wanted to give them a nice lunch. And after 8 to 9 hours, there was a massive but non-hemorrhagic vomiting combined with diarrhea and severe abdominal pain. So on day 1, the lady was admitted to the hospital. The white blood cells and liver parameters increased, and at the Botanical Institute of the University of Vienna, mushrooms were identified as Amanita phalloides. So she received silibinin C, ladies distal infusion. It's more or less cardiac Marianus, or in our country it's now called Silibum Marianum. On day 3, the patient experienced ventricular fibrillation, which was converted to sinus rhythm after 2 defibrillations. There was a need for pharmaceutical cardiac support. Following defibrillation, the patient was comatose. She was intubated for protection of her airways, and she was mechanically ventilated. Now she was transferred to the medical intensive care unit, and she exhibited acute renal failure, therefore received renal replacement therapy via continuous hemofiltration. Patient was stable during the rest of day 3, however, the coagulation disorder started. Now, a liver transplantation was discussed, but it was declined due to the age and multi-organ disease. The patient's family was informed about the extremely poor prognosis and her near death. Now, all of my colleagues said, okay, she will die. And I said, okay, let's start with homeopathy. And she said, okay, she will die anyway. And when looking to the repertoire, I used the rubrics of rectum, diarrhea, aggravated after eating, generalities, intoxication with poisonous mushrooms, and abdomen inflammation, peritonitis, enteritis, liver. So while it is not named in connection with mushroom poisoning, I thought of Arsenicum album. The indication was hepatitis, and it's the first remedy in poisonings and common allergic phenomena. The diagnosis were liver dystrophy, icterus following Amanita phalloides poisoning, and multi-organ failure. So she had at least 4 to 5 organs which did not work properly. Now, regarding differentiation of remedies, intoxication after mushrooms from poisoners, you may also consider agaricus. It's typical as an intoxication with great mental excitement and incoherent talking, and immoderate cheerfulness alternates with melancholy. Physical strength increases. Atropinum is similar to belladonna. There's a suddenness of onset. In belladonna, there might be a red head and severe headache. Camphor includes icy coldness of the whole body with breathing tip of nose and the extremities. Pyrogenium is typical for sepsis and horribly offensive discharges. The bed feels too hard. Now, I prescribed Arsenicum album CH200, and 5 globes were given hourly for 2 days. And the nurses really cooperated in this case. Fantastic. On day 3, the hemodynamic and respiratory situation was stable. However, the liver parameters increased dramatically. On day 4, liver parameters reached a maximum. Now, I again repertorized abdominal liver and region of ailments of then atrophy of the liver, discoloration of the skin, yellow jaundice, icterus. Now, there was a phosphoric state at the onset of liver dystrophy, catabolism, yellow atrophy of liver, and subacute hepatitis with pronounced icterus and suddenness of symptoms, which was prescribed in the Materia Medica. So I prescribed phosphorus CH200, 5 globes hourly for 3 days. We stopped with arsenicum at this time and started with phosphorus. And during this course, patient opened her eyes spontaneously and reacted to verbal stimuli. On day 5, a significant decrease of liver parameters could be observed. On day 6, heart and lung function improved despite the end of sedation. There was no tendency to wake up. On day 7, there was almost no need for cardiac support. Liver parameters decreased continuously. From a neurological side, there was no reaction to pain. However, spontaneous eye-opening signs of encephalopathy and a brain stem syndrome was suspected. The cerebral computer tomography was negative. There was a definite improvement of the liver situation, and now the cerebral situation was in the foreground. Therefore, phosphorus was discontinued. I reported mind unconsciousness, coma, mind answers, stupor returns quickly after. Now, looking to the remedies which might be differentiated in coma, there's Helleborus niger. Actually, I have such a flower which now is flowering, despite it is still relatively cold in my country. Helleborus niger is famous for its profound muscular weakness, the low state of vitality, serious disease. It tends to pix the lip and wet closes. It's similar to Hirsumus, however, here it's unseemly and immodest in acts, gestures, and expressions. Belladonna is characterized by boring of the head into the pillow, hot red skin, a flushed face, throbbing carotides, and burning. In opium, there should be a complete loss of consciousness, an apoplectic state, painlessness, and stertorous breathing. So I decided to prescribe Helleborus niger and CH 205 globals daily for 12 days. Actually, today I might give it more often than once a day, but at this time I just decided like this. At the beginning, there was only a marginal neurologic progress, while the liver parameters increased again. On day 8, the ventilation could be changed to a spontaneous mode, so it was no more controlled mechanical ventilation. The thrombocytes were very low. The sign for inflammatory state, the CRP, the C-reactive protein, was high. On day 11, the pharmacological cardiac support could be stopped, and the CRP as well as liver parameters decreased. On day 15, a tracheotomy was performed, and on day 16, there were a lot of weakly yellowish tracheal secretions promoted by Pseudomonas aeruginosus. Therefore, there was a change of antimicrobial therapy. On day 19, the tracheostomy tube as well as the central venous lines could be removed. The patient was sitting in the bed. She was fully conscious and started to eat again. Now, Helleborus niger was discontinued. The further course showed a constant improvement, and on day 20, the liver parameters were completely normalized. On day 26, the patient could be transferred to the general ward. On day 42, she was discharged from the hospital. Now, looking to the complete situation, it was despite a life-threatening situation, the patient was saved. All specialists agreed to the hopeless prognosis of the 5-organ failure. And 2 other patients who have also eaten at the same time from this mushroom had died. Now, there was a conference, I can't remember exactly where it was. However, there was a group from Bulgaria, and there was a somewhat similar case. Our case is shown on the right side. It's number B. You see Arsenicum album, phosphorus, and Helleborus. And you see the increase in liver parameters and then the fall in liver parameters. On the left side, this case of Bulgaria. It was a young lady, and she had also eaten Amanita flavitis, and she experienced cardiac arrest. And she received phosphorus in a potency of C15. You know, I don't use C15 so much in my country. We use more C6, C12, C30, CH200. But she received this phosphorus 12 times a day. When the liver parameters decreased, the frequency of phosphorus application was now reduced to 3 times a day, then 2 times a day, and finally once a day, and the patient also survived very well. But we have published this, and up to today, except for a few enemies of homeopathy, no one has responded. And I always say, you know, the cost for this treatment is about, you know, in my country, 10 euro about for one bottle of arsenicum and so on. So about, let's say, 30 euro. And it doesn't, in the worst case, it does not help, but it might help. And so far, no one has ever asked me. And I think if you look to the papers regarding mushroom, Amanita falavidis, intoxication, you will not find, there's no evidence, of course, because you cannot make a double-blind study. Now, another point of interest is tracheal hypersecretion. There was a 75-year-old patient, male patient, and he underwent a partial left lung resection because of a metastatic colon carcinoma. And he also suffered from a peripheral arterial occlusive disease. There was a difficult weaning from the respirator because of the total atelectasis of the left lung, but primarily because of massive mucus production, and multiple bronchoscopies were performed without success. Now, extubation was impossible because of this profuse mucus, and repeated suctioning was necessary via the tracheostomy. So I decided to prescribe Kalium bichromicum CH30, which may be called in English literature potassium dichromate CH30. And 3 days later, on day 32, the patient could be extubated. Another patient with a coronary heart disease had an acute situation with stenocardia. He received aortocoronary bypass. Postoperatively, he was transferred to the intensive care unit. He was again weaned from the respirator, but could not be extubated because of the danger of choking due to the profuse, stringy yellow tracheal secretions. Secretions were ropey, especially in the morning. Much secretions, high amounts of secretions could be suctioned. On day 32, the patient was transferred to the ICU, and the diagnosis was tracheal hypersecretion after aortocoronary bypass. Conventionally, the patient was tracheotomized. He was breathing spontaneously with continuous positive air pressure. He received conventionally acetylcysteine and glycopyrronium bromide as a secretolytic therapy, and in addition, enteral feeding via the tube. So I was repertorizing expectoration yellow in the morning, expectoration stringy, expectoration ropey. And the remedies to be differentiated include potassium dichromate or Kalium bichromicum, and of course pulsatilla with yellow secretions, but not so stringy. And the Mercurius solubilis secretions are smelling offensively, and with lachesis, the typical concomitants were missing. So the patient received Kalium bichromicum CH30 twice daily for 3 days, and the amount of tracheal secretion decreased dramatically. Extubation was possible on day 3 after homeopathic treatment. So the quick effect of Kalium bichromicum enabled safe extubation after problems lasting for weeks. And you know, in my country, 1 day at the intensive care unit costs at least 1,500 to 2,000 euros. So it's a big amount. Now, I performed a study published in 2005 in a conventional journal named Chest. And this was the background. We just talked about the stringy profuse tracheal secretions, preventing extubations in patients who were already weaned from the respirator. And this was a prospective randomized double-blind placebo-controlled study with parallel assignment. One part of the patient received Combitube and the other one placebo. You know, most of the patients had a history of tobacco misuse as well as chronic obstructive pulmonary disease, COPD. Now, the patients who were already weaned from the controlled mechanical ventilation now needed only a short period of non-augmented spontaneous breathing. And all these patients were ventilated either via a conventional endotracheal tube or a tracheostomy tube. 50 patients were receiving either Combitube, CH30 or placebo. 5 globals were administered twice daily at intervals of about 12 hours. Now, these were the patient characteristics which were comparable, and parameters recorded showed that the amount of secretions could be reduced dramatically in the group with Combitube. Also, the extubation could happen 3 days earlier, and length of stay could be reduced almost by 50%. So I think Combitube is one of the remedies which are very helpful, and I also experienced this in some other patients. And I just want to show you an evaluation of the thermoluminescence by Professor Louis Rey. Unfortunately, he has deceased many years ago, but he was working and he also published a paper about thermoluminescence of homeopathic remedies. Now going to sepsis syndrome, when I started with intensive care medicine, it was clear a sepsis syndrome has to be caused by either bacteria, virus, or fungi mushrooms. So in 1997, it was a sensation that investigating almost 30,000 patients, 1,300 sepsis syndromes were found, and 59 patients were in the intensive care unit. 11% had not in the ICU, had a positive blood culture. 30% of those patients not in the ICU had a negative blood culture. But altogether, if you look to these 1,300 episodes, only 32% had a positive blood culture. So this is very interesting that 3 out of 10 had a positive blood culture, but about 70% had not. And I think this was a sensation at this time. What I believe is, as you know, sepsis is a severe disease with a mortality of 35 to 60%. There are about 500,000 of cases 1 year in the United States. It's the 13th most frequent cause of death. And there's only a slight improvement of mortality despite increasing therapeutical technology. And as I already emphasized, most of the patients with the sepsis syndrome have no bacteremia, and some of them even no serious bacterial infection. Now, there's a story in Vienna, which is going back to the Middle Ages. There was a big epidemic plague, and I think about 30 to 40% of the European population died at this time. I think it was the 13th or 14th century, as far as I remember. Now, if you look to this Augustine and what has happened, he was a very nice guy and he played a musical instrument. One day he fell into the earth where a lot of corpses of dead people after plague were lying. And because he was drunk, so he fell drunk into this point. The next day, the people working with the corpses found that there's someone stinging in this ground, and they put him out, and he survived. Now my students say he survived because he was drunk and alcohol killed his plague bacillus. Now I think it was much more his good constitution, his positive and good immune system. So if you have an infectious agent, there are two ways to work with it. One is you give antibiotics or antimicrobial therapy. The other one is you are working on the disposition of the patient, as we do with homeopathy. We are not working on the infectious agent, we are just improving the patient's condition and constitution. And this may be also supported by probiotics such as GCSF, which may increase the number of leukocytes. But I think it's the major merit of homeopathy to help the constitution. There's one female patient, she was about 20 years, and she just by chance found out that she was pregnant during the 7th month, because her menstruation was irregular even before, and she did not gain much weight. There was a section necessary with complication because of the amniotic fluid embolism. One day before section, there was a swelling of the right side. 4 days after the section, there was a redness and swelling of the left arm, fever up to 39 degrees. I believe this fever was caused in this sepsis-like state because she had a cannula, a venous cannula, for a few days, and this is not a good thing. On the day 12, there was a pulmonary infarction with pleurisy of the left side, effusion, and the thrombosis of the vena cava inferior. In addition, splenomegaly was documented. Now she received a high-dose anticoagulation therapy, and with the diagnosis of a therapy-resistant sepsis and due to acute respiratory insufficiency, the lady was transferred to the intensive care unit. There, during the next days, a thrombus of the right atrium, a thrombotic occlusion of the vena jugularis interna sinistra, and also side disorders such as sinus thrombosis were found. Inflammatory parameters like CRP increased very heavily to 40, leukocytes increased to 20. On day 42, there was an operative excision of the thrombus from the right atrium combined with the occlusion of an open foramen ovale. She needed high level respiration and high doses of catecholamines. On day 43, a pleural empyema was operated. Now she had a renal insufficiency needing veno-venous mechanical hemofiltration, and in addition resuscitation because of cardiac arrest. Just remember, the lady was about 20 years old. Furthermore, there was a site dysfunction of the liver function coagulation. On day 58, she could be extubated. However, 2 days later, she had to be re-intubated. So, due to the thrombosis in the pelvis and the feet, she received on day 68 a cover shield implantation. There were multiple abscesses in the area of the breast and button, which were drained and taught. The bacteriology all the time was negative. On day 73, there was a new extubation, and on day 84, a thrombosis of the vena subclavia sinistra was found. The inflammatory parameters were highly increased, and the fever was all the time for weeks and months between 37.5 and 39 degrees of Celsius. The hematostasiological investigation only revealed heterozygous prothrombin polymorphism, but this was not assumed as the reason for the coagulation dysfunction. Now, repertorization was performed, and I decided finally there were two remedies which might be suggested: pulsatilla and lachesis. Now, I decided to use lachesis muta LM18, which I had just with me once per day. The next day, you know, I was introduced to this patient on day 95, after about 3 months at the ICU. Next day, the temperature dropped to 37 degrees, and the patient suddenly exhibited appetite. And, you know, her father, he was so embarrassed because she did not eat all the time. And he repeated this, his care about this several times. At the same time, the same day, she was sitting in an armchair. On day 97, 2 days later, there was a decrease of the pronounced face edema, but there was an increase of the lower leg edema. You know, this, as you know, this fits very well into the Herring's law that symptoms should disappear from above downwards. The inflammatory parameter was decreased about to 50%. A few days later, the antibiotics could be cancelled, and next day there was a removal of the stomach tube, and there was no more ascites. Further medication included lachesis and also pulsatilla. Then I gave once more lachesis. You know, if you look to the story afterwards, sometimes I think, okay, why did I decide this or that? Actually, it may be also because the patient started to take part in her life again. Now, it was the first time that she asked for her son. You know, there was a section, and she hadn't seen her son for 3 months. And now she was interested how he was doing, and therefore her mood was, of course, in a very low state. And of interest, as I reported before, suddenly an upper leg eczema appeared. However, this edema and the eczema disappeared soon after, and on day 131, the patient could be discharged from the hospital. Now, before this, I have already had some interest in these patients with severe sepsis, and I performed a randomized double-blind study in the intensive care unit, and it was performed in 70 patients receiving either homeopathic treatment or placebo. 5 glues in a potency of 200 CH were given at 12 hours intervals during a stay at the ICU, and the survival was recorded after 30 and 180 days. The sepsis criteria were used as proposed by Bone criteria, which are still in use with a little modification. And I don't want to stress you or bore you with this, but more or less the characterism of the demographics was comparable between the two groups. After 30 days, the difference in survival was not significant, but it was significant after 180 days using Goscal-Wallis test. Now, this study was criticized because Cuscavalis may not be perfect. Actually, my problem is I am not a statistician. So later on, we performed the T-quadrat test, and it also showed a significant p-value when you use the per protocol analysis. You know, per protocol means, for those of you who are not so familiar with studies, that you only include those patients who really followed the protocol. But if someone stopped, for example, or medication was stopped, or the patient did not want to proceed with the study, then you exclude this patient. Now, interestingly, opposite to my suggestion, if you use the intention to treat analysis, which means all patients who have ever started after agreement to the study will be included in the study, even if they change completely. It could be, for example, that someone who is in the placebo group now decides, I want to use homeopathy on my own. You still have to include this patient in the placebo group. And interestingly, I was really surprised, the T-quadrat test also showed a significant level. So we are very happy about the results of this study. This is just an overview of the remedies used, most often used homeopathic remedies. So we believe that especially in all inflammatory diseases such as sepsis, homeopathy might be helpful. This is just the time when I was in Jaipur 24 years ago. And now I can stop. I think I'm not talking about 1.5 hours, or we want to just hear about this premature infant.
You may continue, sir. It's very interesting. And yeah, the limitations of the research which you had explained was wonderful. And it is very questionable, you know, we all have so many doubts regarding the scientific research and how to bring homeopathy into the mainstream research. That's one thing which we are probing into. Sir, if you have time, you can continue with this premature infant case also.
So I understand I should proceed with this case.
Yes, you can proceed.
Okay. This is a premature infant. A twin died intrauterine. The section took place in the 26th week after complete maturing of the lungs because of early rupture of the membranes with hemorrhage 41 days before. The infant was weighing up 810 grams, and the laboratory parameters of the mother were normal. The first week, the infant received nasal continuous positive airway pressure ventilatory support, and there was little breathing by himself. A intratracheally surfactant was administered, so because oxygen saturation fell from 100 to 80%. So after 1.5 hour intubation, a second administration of the surfactant was performed. Due to the extreme immature lungs and lung hyperplasia, I again decided for Coprometallicum CH200, and the cerebral ultrasound revealed intraventricular bleeding on day 3. And if you look to the repertory with head cerebral hemorrhage, also ipecacuanha is mentioned. So I decided to give additionally ipecacuanha. Of course, you could also consider opium or belladonna and many others, as you know from the repertoire. The following days were unremarkable except for the interventricular hemorrhage on both sides with a progressive post-hemorrhagic ventricular extension. On day 7, there were cramps, which were treated conventionally by luminal. EEG was normal. On day 10, the CRP was increasing. Pneumonia was suspected, so I decided to give phosphorus CH200. And I repeated phosphorus 2 days later. On day 59, the patient could be transferred to intermediate care. There were fluctuations of the arterial oxygenation and bradycardia was observed. The infant received oxygen mask and packed red blood cells. The cerebral MRI from day 66 showed an increase of the size of the left ventricle. On day 70, the patient was transferred to the neonatal intensive care unit and received the ventricular peritoneal shunt. Preoperatively, I was treating this patient. I've never seen this patient. I just had telephone calls with the mother of the patient. So she gave the patient Anika CH30. And on day 72, I decided for Esculus D6 and Silicea. But I don't know why I did this, because the problem was with telephone, I did not make documentation properly. So I just know it was given, but I don't remember why. Subsequently, the ultrasound showed that the ventricular size decreased, and the top of the shunt was at the anterior horn of the left ventricle. On day 81, a partial retinopathy of prematurity was recognized, and laser treatment was performed on both eyes. So I gave pulsatilla and Ahios thermos, and since the day 31, there was a complete enteral nutrition. There was a growth and gain in weight parallel to interuterine growth percentile. The patient received 400 milliliters of mother's milk and also was breastfed. On day 92, there was a discharge from the ICU to the general ward, but the oxygen saturation decreased. So I decided to give Grindelia in the Materia Medica of Böhringer. It is described a choking after falling asleep. It stops breathing when falling asleep, startles from sleep, and gasps, has to sit up for breathing. Now, Grindelia, I also like to prescribe in adult patients suffering from oxygenation or breathing gaps. And I have the feeling this is also helpful. So the rubric is respiration arrested, sleep going to Grindelia analysis. Now on days 161, I prescribed camphor, and because the patient was feeling cold, there were extreme milk crusts and beginning of eczema on the head. So the patient received antimonium crudum or stibum sulfatum nigrum for 3 days. It was day 200. Now, the interesting thing was, at the same time, 2 other premature infants with sufficient maturity of lungs and interventricular cerebral hemorrhage died. Now, as long as the mother was at the hospital with her child, and just before she could, the infant was discharged from the hospital, one of the colleagues came into the room of the general ward And he said, no, I have to look to the history of your child because two others have died and we don't know why. And the mother said, just to let you know, but you know, it was not a secret. We have given my child also homeopathy. But he said, no, this cannot be. So, the conventional colleagues did not learn from this case or did not want to learn from this case. And even I never say it must have been homeopathy, but obviously it could have been. I think this is what we should always keep in mind. There's a difference between possibility and evidence, of course. It was an individual case with respectable reactions. It was a perfect teamwork with the mother. And there are, as you know, small costs and free of side effects, and it's easy to practice. So I think we can learn from each case, and I hope you have some, you've got some suggestions and energy and motivation to use homeopathy in intensive care unit as well as in emergency situations. Thank you for your attendance.
The cases were so interesting and wonderful. And lastly, when you said, my colleagues were searching for a reason, that was the wonderful part of it.
Thank you so much.
In one of the aphorisms, our master, Dr. Hahnemann, has said that don't search for reasons. The symptoms. Okay, focus on the symptoms and the case taking, and then your cure is there, sure for the cure. So, ending this webinar of Dr. Frass, I thank you deeply from my heart that you have come here and graced the presence and presented this webinar. I would request if any of our members have any doubts and questions.
Yeah, I have one doubt. Actually, what we are doing, we are giving very low potency in infants or children under 10 years. Here in infant case, doctor used LM potency. So
Yes.
I just want to know what is the reason. And even in sepsis case, he gave first LM, then 200, then XM means 10M. So how 200 in between? Why he has withdrawn the dose and again 10M?
I've just excused because, you know, I have some impairment of my ears and
Yeah. I will explain the question. She wants to, Dr. Kamini Pandya, she wants to know why you have given very low potencies to the patients in ICU. And
high potency, high. He has used high potency in some cases. In sepsis also and in infant potency also.
Yes, in some cases you have prescribed around 200 potencies. What was the reason she was asking?
And LM first LM, then 200, then XM, and 10M.
Yes.
So why it is so?
You know, sometimes it was just due to the availability. Sometimes I had, in most cases, I would think CH200 is very good. I have also a friend, and he also uses even higher potencies. So sometimes it may be useful to use 1000 CH1000 or even a million. Sometimes I only had this LM potencies because the lady with the sepsis, when I first used the Lapis LM18 or LM12, I don't know, it was just one day before Christmas, 2 days before. So I didn't have the chance to organize the CH200. What I believe in most cases, I think it's necessary to find the correct remedy, and potency may be secondary. However, in some cases, I have the feeling it should be higher or even very high very high potency. But this is something we can only find out. Also, repetition may be sometimes necessary. There was a case, an emergency case of a friend of mine. He was very obese and he fell down during winter time, and he fell on his coccyx, I don't know how to, on his spine. And he could not sit, he could not lie, and he could not walk. It was everything very painful. And he was afraid of hospitals and doctors. He avoided to go there. But after 2 days, he called me and I prescribed him Hypericum. And after the first time, nothing happened. It was a CH30. And after the second time, a few hours later, he, as a mechanic, he was a mechanical person, a technician, he reported that he had the feelings that something is sewing in his spine, in his bone, and after 5 minutes, it's very painful. The pain is increasing, and after 5 minutes, a part of the spine is flying away. Then it was a little bit better, and then again, it was like a saw through his bone, and again, the pain was going up, and something is flying away. And after 2 hours, everything stopped, and he was almost pain-free, not completely, but much better, and everything improved. So I believe, as I showed in this lady with Amanita phalloides intoxication, I believe in these ladies, hourly repetition was very important. The problem was, sometimes the nurses are very cooperative and sometimes not. So I could not always perform as I wanted to do. So I hope I could answer a little bit.
That was
But
a very
sir,
good
one more. But sir, you have continued this high potency for 18 days. We are getting scared to give some higher potency repeatedly. So if aggravation occurs, we people are very scared. We give one high potency and then leave patient for days together because high potency will hurt. Here you have repeatedly given for 18 days. So this surprised me.
It was the lady from the Amanita phalloides, or?
Sepsis.
Yeah, I will interpret for her. She wants to know that the higher potency was given for almost 18 days. So what if homeopathic aggravation happens? How would you handle it? It's very scary for the Indian homeopaths to give the high potency.
And
that's what she says.
And repeatedly too.
As far as I understand, I think there may be an aggravation or a homeopathic reaction. When I first used in this lady with Amanita phalloides, the arsenicum and the phosphor, I think there was a strong reaction. Whether or not, I don't believe so. Arsenicum was responsible for the increase of the dramatic increase of the liver parameters. I don't think so, but I think it's more or less the natural course of Amanita phalloides poisoning. But later on, when the patient's acute situation was already covered, and when I started with the Helleborus, I think I should have given it this also hourly. Maybe when I look to it now, I think, why did I not? But, sometimes I had to decide very quickly, and, this is also happening besides my regular work, but it was happening besides my regular work at the hospital. So I think it might have shortened the stay at the ICU if I would have given the Helleborus hourly, or at least several times a day. And this is something here we could bring together our experience, and I can just report what I have seen, but I don't want to pretend that this is the last solution. I just believe it is one way to treat but you may have another way to use other potencies. As you know, I just know from the South American homeopath, like Campora, he's using extreme potencies daily. The only difference to me seems that he's using Korsakoff potencies and not CH potencies. In my cancer patients, I prefer to use Q potencies, you know, the liquid form of LM. And I think this is very helpful. So with the Q potencies, I'm influenced by Darius Benetti, for example, you know. I think the height of potency as well as the repetition is still a question to debate. So it's not something I would say it has to be like this.
Yeah, that was wonderful. Yeah, what I observed from the total presentation was that first thing, science doesn't happen simply without any exploration. That is what scientific research is about. And when I saw the presentation, the different cases which were presented were all hopeless cases, where already Dr. Frass' colleagues had given up and they were just waiting for the patient to die. And Dr. Frass came forward and gave the homeopathic medicines. And fortunately, all of his patients, they survived. And that is the great thing. So one lesson to take from this is we all need to explore and not just be hopeless of the cases. And that can be done only if we are given a chance to explore in the ICUs. With these hopeless cases where patients are about to die, why can't homeopaths try a hand on them to revive them, to make them survive from their critical illness? This is one big question which I would like to ask the health authorities in India, so that homeopaths get a chance to explore the science of homeopathy in the ICUs of the hospitals, in the general wards, in every field, so that we can work together and help in the patient care. One more case-related thing is that Amanita pallidus. This is a mushroom variety which is found in the northeast and the north states of India. And every year, reportedly, we have around 20 serious cases. Almost people die because of this poisoning. And almost there are around 10 to 15 cases of mild poisoning as well. So how important it is to introduce homeopathy for such kind of poisoning cases. We can explore this aspect as well. So another thing about the scientific research is there are certain limitations. Why? Because our scientific research related to homeopathy doesn't collide with the scientific research which is prescribed by the Cochrane Committee. So we have a different type of proving where homeopathic medicines are proved totally on a different principles. And the homeopathic medicines are also given totally on the basis of the symptoms. Now, coming to this aspect, it is very important that we need to explore this aspect of scientific research. And I feel that there is a need for a different scientific aspect of conducting a research with the homeopathic perspective. There are thousands of research articles which are found on the internet. Just like Dr. Frass has put up this research. In a similar way, we find so many research articles, but why is still homeopathy not considered as scientific? When we go out in the internet and search for homeopathy, there is a bold line sentence: homeopathy is not scientific, it is a placebo. So this is a big question where it has to be eliminated, and we need to establish a scientific research protocol completely based on homeopathic perspective. Because it works, we all know about it. What do you say about this, Dr. Michael Frass?
You're completely right. I'm sure that homeopathy is working. If you look to the meta-analysis which have been published up to 2005, 5 of them were at least somewhat positive that homeopathy works better than placebo. Only the publication in Lancet 2005 denied any effect of homeopathy. However, at this time, we sent a letter to Lancet, which was never published under strange circumstances. But we have published this letter in other journals that this Lancet meta-analysis is suffering from a lot of difficulties and wrong assumptions. So this Lancet paper is not reliable. In addition, we have this Australian report is very strange because they have reduced the number of papers included to 5 of the exclusion of all papers with a number of participants less than 150, which is also strange. It's not a regular way. Even Cochrane database doesn't request at least 150 participants. And we have published as the lady who is the president of the Austrian Society of Veterinary Homeopathic Medicine, Dr. Petra Weiermeier. She has published a paper in a Swiss journal, in a conventional journal about homeopathy, and this was also translated into English. And this also confirms that homeopathy does more than placebo. I think the main problem actually is that you are treating individually, and these cases I have presented are not suggested as evidence, except for the papers I have published. But the main problem seems to be that homeopathy cannot work because there's nothing in it. Now, there's an Austrian Nobel Prize winner with quantum physics. And, you know, in quantum physics, you are describing that one small particle is influencing another particle which is far away and has no direct connection. It may be also that the second particle is using the information of the particle one. Also, particle one has not sent the information so far. So I think this is completely strange. While in homeopathy, we at least apply the globus to the mucous membrane of the patient, the oral cavity. So I think most of the, one of the problems is that Mr. Sackett, I think 1996 or 1997, he described, or he was inventing evidence-based medicine, and he said it's evidence is founded by the experience of the physician, by the preference of the patient, and also by the best external evidence, which is research. But now, today, the discussion is only about research and studies, and no one looks to the patient, no one looks to the physician's experience. But it should be 3 points and not one single point. And even this single point is much better, as you already told. One of the main problems may be that most of the homeopathic research is not done in a hospital. And even in a hospital, as I was doing, there are still points to consider, and besides study itself and the treatment of the patient, you also have to take care of a lot of administrative work. It's unbelievable. It's ethical committee, it's an international platform, and for example, we also had to inform the European drug society. And all this together takes a lot of time, and it also takes a lot of money. It's not possible to perform a double-blind prospective study in an office, in a private office.
Yes, correct. So that is one of the one of the obstacles of research, scientific research in homeopathy, not able to control or make the double control, blind control studies and the provings. Okay, all these. So is it possible that we have a separate committee, scientific committee, just like the Cochrane committee or the Lancet, which reviews the articles, the scientific research papers? That is one of the necessity I feel for developing the scientific research in homeopathy.
What I could send out is both from the German Society for Scientific Homeopathy, who have put together a so-called research reader. I'm not sure it's in English, but at least I can send you the English version of this Swiss paper. I think this is a very good overview.
Finally, to conclude this webinar, I would conclude with telling that all of you, Dr. Frass has authored a book which is called as the Homeopathy in Intensive Care and Emergency Medicine. And in this book, he has presented around 145 interesting cases, which we all would like to study, and it is available at Verlag Publishers, Narayana Publishers, Germany. And it is available there. The link can be put up in the chat. And you can even search through Google and go to Narayana Verlag and get it from there. I'm asking Dr. Frass has sent a mail regarding sending the book to us. And we are just looking forward to get the book. So those who are listening to this, those who are watching it on YouTube, if you want this book, you can directly contact us for the book and it will be available to you.
Thank you so much.
Thank you, Dr. Frass. Thank you, Dr. Frass, for being here. It was a very wonderful webinar and all the cases were so interesting. And I hope we'll collaborate in future too for such webinars. Thank you so much.
Thank you so much. Greetings to India.
Thank you. Namaste.
Bye.
Yeah. Thank you. Namaste. Namaste, sir. I'm stopping the